Hello, I'm Dr. Howard Hochster from the Yale Cancer Center, where I'm the Associate Director for Clinical Sciences and the head of GI Oncology. Today we're here to talk about the Oncotype DX colon cancer assay. And with me today are two of my colleagues, Dr. Deborah Nagel and Dr. Darren Wheeler.
I'm Deborah Nagel, and I'm the Chief of Colon and Rectal Surgery at Beth Israel Deaconess Hospital in Boston.
And I'm Dr. Darren Wheeler, the West Regional Anatomic Pathology Director for Quest Diagnostics.
So today we'd like to discuss the problem of stage 2 colon cancer and how we can best decide on the appropriate therapy for patients who have this stage of colon cancer following surgery. The problem that we have today is with stage 2 colon cancer that many patients are cured with surgery alone, but some percentage, probably around 20% plus minus 5%, are going to recur. So we'd like to really be able to prognosticate better on who needs more aggressive therapy or no therapy. Dr. Nagel, what's your general approach with this stage 2 colon cancer?
So I'll just echo the fact that we find it perplexing because we know that a percentage of patients will recur, and to date we really have not had any good markers, I would say, to help us define who will benefit from chemo and who will not. So far, we've been using additional pathological features like LVI or differentiation to help guide us to patients who might have a worse prognosis and therefore might get the marginal benefit from chemotherapy in stage 2.
Right, and I mean, we try to hang our hats on these kind of weak pathologic nails, but what we find is that there are some stage 2s that behave badly and some that behave quite well, so that's the challenge. Dr. Wheeler, your thoughts about the staging?
Yeah, I agree. I think as pathologists, we're constantly studying different histopathologic features that may help us kind of categorize some of these stage 2 tumors into those that will have a more aggressive behavior. And we're not always able to do so, thinking in particular of things we know as strong prognostic indicators like lymphovascular invasion. We're not very good at identifying it, and I think most pathologists will tell you that when you see a bona fide lymphovascular invasion feature, it's often associated with lymph node metastasis at that time, and of course then you're already out of the stage 2 category. So I think that there are a number of histopathologic features, but whether we can give 100% certainty to our surgery colleagues to know that that is something that you can hang your hat on as far as the way you're going to treat that patient is questionable.
I think the other issue about the histopath features is that when we're together in our hospital in tumor board and we're discussing should we recommend chemo for this patient who's node negative but has these features, time and again the comment comes up that lymph node status trumps everything else. And so the strength of the lymph node positivity is such that we clearly know we go to chemotherapy, and so relative to that, many times people don't feel comfortable recommending chemotherapy, even if there are a host of other histopath features.
Right. I mean, I think the problem in terms of recommending therapy is that there is no definitive clinical trial. It's a little bit like adjuvant therapy of breast cancer before we had the node negative data. To develop that data, we need a much larger study with much longer follow-up, and we just haven't done such a study. In fact, most of the adjuvant trials to date had mix of stage 2 and stage 3. So for stage 2, we're really talking about either T3, T4, and node negative. And we know that even though the overall survival is probably 85%, within that group, we see that with bad features, people may have as high as a 30 to 35% relapse risk. And so the question is still, can we use other factors to help us prognosticate and therefore pick the best adjuvant treatment to guarantee the best outcome?
When I look at the stage 2 tumors, we try to kind of separate them into different categories where, those that you want to treat, those that you don't, or at least to provide that information on our pathology report to the treating physician so that they can, accurately kind of break that whole subset up. Obviously, if you look at the NCCN guidelines for who you treat, it can be everything from observation to, clinical trial. we're not doing too good of a job at that right now, just based on histopathologic features. But I think, for us right now, in our minds, we think about those tumors that are in that node negative category, that are not perforating the serosa, not T4 tumors. I think the T4s, I think most people would recommend, more adjuvant therapy for those patients.
Even node negative.
In the node
right.
negative subset. MSI tumors, we know, have a good prognosis, so you're not going to treat those. But even eliminating those two categories, you're still left with a large amount of patients in that stage 2 node negative category that, it's a question whether you give them adjuvant therapy or not.
Right. Stage 2 is about 25% of the cases in the U.S. So if we have 60,000 new colorectal cancer diagnoses a year, that means we're probably talking about 15,000 patients who fall into the stage 2 category. So it's something that we all see with some regularity.
The other feature that I find confusing sometimes is that because we can't accurately identify which of the stage 2 patients would best or most benefit from chemotherapy, you have to wonder, are we giving the optimal therapy when we give it? And so, as I understand it, most of the trials were done and that show that node negative doesn't necessarily need FOLFOX because they do just as well with Xeloda. But maybe if we could say which patients were at a higher risk of relapse, maybe those patients would benefit from FOLFOX or some other therapeutic regimen.
Right, and we have some data on that from the NSABP trial to support that. But the best trial that we have today still is the QUASAR trial from England, conducted by the MRC. QUASAR standard for quick, simple, and reliable, and it shows about a 3 to 4% absolute benefit rate for a fluoropyrimidine for stage 2 colon cancer. So, that's kind of the baseline that we're looking at. The unfortunate part about the other trials where people say, well, the combination chemotherapy didn't work, is that the sample sizes were too small to really give you enough power to show a difference. So, still kind of left in this data-free zone where we need to extrapolate. Well, that was a very interesting discussion. Thank you, Darren and Deborah, for that discussion on staging of colorectal cancer and the outcomes with survival based on the current staging techniques.
My pleasure.